All right, good evening, everyone. I'd like to welcome everyone to tonight's MSIG webinar, where we're continuing the webinar series on textbook injuries, where we'll have each speaker here share their expertise on a specific sport and identify the most common injury or injuries from the sport. My name is Bill Khawaja Sadiq, and I will be serving as your moderator for tonight's webinar. I am an MS2 at Midwestern University in Chicago, Illinois. After all of our speakers have shared their presentations, I'll be serving as the moderator for a Q&A for our speakers. So if you have any questions, please hold on to them or write them down or keep them in your head. You'll get a chance to ask, but we're going to go ahead and let everyone present first so we can get through all the presentations, okay? So let's start off. It's my pleasure to introduce our first speaker, Dr. Kari Kinschi. She's a very proud Badger from Wisconsin. Dr. Kindschi graduated from medical school and family medicine residency at the University of Wisconsin School of Medicine and Public Health, and then she completed a primary care sports medicine fellowship at Duke University. She received a Master of Public Health from Johns Hopkins University, focusing on injury control, health communication, and health education. Dr. Kindschi works in Baltimore at MedStar Health, providing care to athletes of all ages and skills, and she currently serves as a team physician for Morgan State University. Over the last 7 years, she has worked with USA Lacrosse in many capacities, most recently with the U20 women's national team for the World Lacrosse 2024 Championship in Hong Kong. Dr. Kindschi, you have the floor.
All right. So one of the things that we wanted to make sure that we talked about when we first started is kind of how we got involved in the sport. And my journey into lacrosse didn't really start with growing up with it. I grew up in Wisconsin and wasn't exposed to it till my fellowship. I lucked out, and my fellowship year, my team won the national championship. So it was a pretty great start from the beginning. I literally got my job on a lacrosse field. And so I now have built a practice in Baltimore where lacrosse is just a hotbed of activity. So currently I work at the MedStar Health Clinic in the ground floor of the USA Lacrosse headquarters, and have the opportunity to work with athletes of all ages and skill levels who come to the field to play. And if you're not used to lacrosse, it is a dynamic, fast-paced field game with a stick and a ball and people coming at each other to try and score. There's a lot of interest in some of the newer versions of the game, but most of us have the exposure to the field lacrosse game. The box game is growing in leaps and bounds and just had their world championships up in Utica. And that's more of a lacrosse game that's in a like a indoor soccer arena. Where we're really seeing the growth now is in the sixes, which is the fast-paced, short-sided game that's going to be part of the Olympics in 2028. What I wanted to talk about today is really an overuse injury. And so that speaks to the nature of the game from a lot of levels, but also the environment with which it's played. And so as we think about the pressure on the athletes to play in multiple different teams and the volume of training that they're doing, it leads to an increased risk of overuse injuries. So that's really what we're talking about today. Spondylolysis is our stress injury through the pars intra-articularis of the spine. If we think about the spine, it's got a posterior vertebral arch, and the weakest part of that arch is the pars. The pars doesn't reach full bony maturity till about age 25. And so when we think about spondylolysis, we're thinking about an overuse injury that's common in growing athletes. Often I will see these injuries just after or around the time of a growth spurt. When we think about overuse injuries, we think about the repetitive hyperextension of some of the activities that happen in lacrosse, like shooting. Shooting is going to involve lumbar extension and some rotation, and it's those two components together that cause some increased risk of muscles fatiguing and the load of the activity shifting to the bones. The classic person walking in the door is an active adolescent with activity-based back pain in extension. We see it a little bit more often in men than women, and most often we're seeing it at L5. So if we think about L5, we're thinking about the bend, one of the bendiest parts of the spine connected to the part of the spine that doesn't move a lot, but it's a little bit more than that. If we think about the facets that are kind of the hinges in the back of the back, L5 sits over top of the S1 facet. The S1 facet sits a little bit more posterior with a posterior facing facet. And it's that combination that leads to a little bit more anterior shear on that L5 pars area. When we think about the spondylolysis, we can think about it as unilateral or bilateral, but if we have bilateral pars stress fractures, then we have an increased risk of a listhesis, where we're going to have anterior translation of the vertebral body over the vertebral body below it. So if we think about the exam findings, we want to think about what we're going to see, and that's tenderness to palpation along the midline. We're going to see pain in the low back or sometimes into the glutes with lumbar extension. Often we're seeing hamstring tightness. And while we don't have great magical tests for this particular one, the best one we have is the one leg hyperextension test. So where we're going to see that is an athlete's going to stand in front of us, stand on one leg and bend backwards. A positive test is one that reproduces the pain with that lean backwards. The trouble with this is, like most of our orthopedic tests, we have a low sensitivity and low specificity for this one, but it's kind of the best we have. When we have concern about this injury, we're also going to think about imaging. So on the pictures on the side, we have our X-ray and we have our MRI. And there's a lot of controversy about imaging because there's no universal pathway or algorithm for this. Often we're starting with X-rays because that's what we have. Typically it's an AP, a lateral, and both obliques. But there's a lot of controversy about how much value we get from the obliques versus the increased radiation that we have. We may see some sclerosis in the area of the pars with an AP. We may see the alignment on the lateral, but it's hard sometimes to have the classic Scotty dog finding that we're shown in this X-ray here. Now, typically on your board exams or on testing, this is the classic finding. It's the oblique view that has the Scotty dog in the profile. So you can see the silhouette there of the Scotty dog at the same level of the L4 it is on this one, but yeah, and you can see that we want our Scotty dogs running free. Once they have a collar, then we're concerned about a pars stress injury. So the one right above it has a happy, healthy neck. The one that's right at the level of the silhouette of the Scotty dog is the one that has the collar. I found that as I've done this longer and longer, I tend to be an earlier advocate of getting an MRI sooner because an MRI doesn't have any radiation, but it also gives me a little bit more detail about the inner part of the bone. I'm able to see a stress reaction before the fracture line appears. If I think about bones on X-rays, I think about them like M&Ms. I can see the hard candy shell, but I can't see the solid center. On the MRI, I can see the solid center. And I also get the value of a test that doesn't have radiation and a test that shows me some soft tissue structures around it. The advanced imaging continues on, and these are the CT scan and the nuclear medicine scans are ones that I don't often order. But the CT scan would be kind of our gold standard for further evaluating a fracture line. Getting a little bit more detail. It doesn't tell me the acuity of it, but it tells me where it is, if it's got both cortical edges involved, if it's a complete fracture. There's a lot of radiation to it, so if we're going to pursue this, a lot of times we're asking for a thin slice CT right at the level we're concerned about to minimize that. The bone scan, again, I have not ordered this in a long time just because there's not a lot of bony detail, but where it does give us some benefit is in the acuity of the injury. When we're thinking about this, this is, of course, one of our professional athletes here in her prime hyperextension rotation mode to score. And the key thing for this spondylolysis is that most of these do well with conservative care. The foundation of treatment is really on rest and avoiding hyperextension and figuring out when the right time to start physical therapy is. As I've done this longer and longer, I realize that there are a lot of different ways, and this is the art of medicine about when you're going to introduce physical therapy. What I've tended to do that has worked well lately is work a little bit on, once the activities of daily living are pain-free, that tends to be the time when I'm trying to get people involved in physical therapy. And for therapy, I have a couple of different phases. So the first phase is really focused on hip and core programs, trunk stability, and flexibility training. The second phase, once they've successfully gotten through that one, is a little bit more of a sport-specific functional movement phase. Bracing is kind of plus or minus. I really don't have strong evidence that pushes me to do this, and so I haven't really done this in a long time. But there is some evidence about bracing. For me, when I used it in the past, it just got a little bit less practical as I was trying to go through it, because the braces needed to be custom. They never got there when I needed them to. They were costly, and the kids hated being in them. So by the time they got to bracing, they were largely pain-free and had improved anyway. So without strong evidence in the literature, and with it being just not very practical as I was doing it in my clinical practice, this is one that I have not done in a long time. There are some implications of recurrence or progression of the spondy, and certainly chronic low back pain in the setting of a listhesis is something we think a lot about. There are people in my practice who have done injections and even surgery for these, but that is the very rare case. The reason to kind of bring it up in this and to have a setting with an overuse injury among the panel today is just to make sure that we've had the conversation, because I'm seeing this in my clinic with kids who are younger and younger. And if we're not affecting the environment in which they are playing and training and competing, I think we're going to start to see progression and things that follow kids into their futures. So while it's not probably the right conversation to have in this group, but it's one to kind of start the process and the conversation of having as some of the load management, load limiting kind of conversations, similar to what we do with baseball and pitch counts. There's not really a real clear parallel to what we're talking about with what we would be limiting, but I think it's a conversation worth having and a conversation to think about. So that is lacrosse in a nutshell, with one of our most common, although not the most common, but certainly one I'm seeing more often. And I will turn this over to the next person.
Thank you, Dr. Kinschi, for your presentation. We appreciate you. Now, moving right along, because we have quite a few speakers tonight, it's my pleasure to introduce Dr. Margot Putukian. Dr. Putukian is the Chief Medical Officer for Major League Soccer and a past president for the AMSSM. She is the former Director of Athletic Medicine and the head team physician at Princeton University. She has been a team physician with U.S. Soccer, working with the women's national team as well as their youth national team since 1996. And now, Dr. Putukian, please proceed with your presentation.
Thank you. I'm really excited about tonight, and I don't have any disclosures related to the talk. But importantly, the views presented are my own and not reflective of any of the organizations that I work with or consult with. So we were asked to talk a little bit about how we got involved in the sport, the biomechanics of the sport, the most common injury, some exam skills to diagnose the injury, and then briefly about treatment and recovery, and I added prevention. So we'll go from there. And I got involved in the sport just as a player, and then also as a coach. So the year between college and med school, I ended up coaching at Boston University. I also had been coaching at a bunch of different camps, but most notably the Lake Placid Soccer Center. And I continued to play and was also working at their Dawn to Dark Festival and working with an organization called Teams USA, where we brought kids to Europe. Did that for 3 summers, including my first 2 years of med school. My fellowship year at Michigan State was requested to sort of do an injury study. And so I ended up doing an injury study at the Dawn to Dark Festival, and ended up presenting my research at a soccer symposium. And at that time, I ended up talking to somebody because there was a presenter about U.S. Soccer, and I went up to them and said, how do I get involved in being a team doctor? And they referred me to a coordinator, and the coordinator basically said, well, what are you doing in 2 weeks? I need a doctor. And that was my entrance into working with U.S. Soccer. I went to Honduras with our under 19 men, and then was assigned to the under 17 boys. But there was, it didn't take long for me to be shifted over to the women's national team that was coached by Tony DeChico. I worked with them until April Heinrichs came in 2000, at which point she brought in her own medical staff, and I then started working with some of the younger teams. In 2014, I started working as the consultant for primary care sports medicine with MLS, and in November of 2018 was asked to take on the role of chief medical officer. And since then, I've been working, fortunately, with the full team again since 2021, and have also worked with the youth teams. And these pictures are from the Pan Am Games, and then also from the recent World Cup for the under 20s. In terms of the biomechanics of the sport, I thought it's probably easiest just to show you some videos. Soccer is a sport where it's an endurance-based sport with intermittent sprinting. It's got a lot of sport-specific skills that include a lot of cutting and change of direction, ball control, passing and shooting, and the unique skill of heading, which is one of the things that makes it slightly different. But I think you can get a sense from the videos of just how much lower extremity demand is there in the cutting and the changing of direction. In terms of the most common injury, if you look at the literature, and it's the soft tissue injuries are the most predominant, and specifically the lower extremity. So whether it's the hamstring, the adductors are the most significant injuries. If you look at youth level, it's the same. It's also soft tissue injuries. The difference there is that between men and women, women tend to have more knee injuries and tend to also have a higher reported incidence of concussion. If you look at the MLS data, it's the same, and the most common injury is a hamstring strain. So that's the injury that we're going to talk about, and this will just show you.
And he makes a little move right here.
Typical mechanism.
You can see he makes that cut and feels it on his right hamstring, immediately go in his head right off.
So that's the injury that occurs, and I think the anatomy, I won't spend any time on this slide, but hopefully everyone's comfortable with the anatomy of the hamstrings. And in terms of the mechanism, it's either a sprint type or a stretch type, and in soccer, it's most commonly a sprint type, which occurs between the late swing phase and the early stance phase, and most commonly involves the biceps femoris. The stretch type also occurs, and you can see it's typically when the trunk is flexed and the knee is extended, so typically with a high kick. And in this situation, the semimembranosus is more commonly affected, which can take a little bit longer to recover. The most common risk factors are previous hamstring injury and age, and there are other risk factors that you should consider. A lot of this comes from the team physician consensus statement that was published a couple of years ago on musculoskeletal injury. There's a variety of grading systems, and again, there's probably five, 6, or 7 of them. The one that we use in MLS is BAMIC, but there's not really a universally preferred system. In terms of presentation, oftentimes it's someone grabbing for acute onset of pain in the posterior thigh. Sometimes they'll hear or feel a pop or a pulling sensation. And then on examination, depending on when you see them, they'll have ecchymosis or obvious deformity. They'll have tenderness. They'll potentially have a defect, and they'll have pain with passive stretch or pain or weakness with resisted knee flexion. For some, it's helpful to look at hamstring flexibility, and we'll talk a little bit about the fact that it's important to also assess the length of tenderness. In terms of imaging, if it's someone that's young, you want to think about an apophyseal injury or a bony avulsion, then you think about radiographs. Typically, MRI is really the most common tool. And there's a lot of literature as it relates to whether you can use MRI or ultrasound as it relates to being able to determine prognosis and the risk of recurrent injury. And bottom line is that the folks that have done a lot of work in this come from are in Aspetar, and there's not a lot of great data to tell us that MRI can help us. It's actually better to use your physical exam skills. This is a YouTube, if you go to YouTube and put in either Aspetar, Johan Toll, Rod Whiteley, or Adam Weir, they're phenomenal. And this is just a presentation where it basically shows that if you have an MRI that has fiber disruption or a grade 2 without disruption and with disruption, you can see that the time to return to play is overlapping. So there's really no difference. And again, Rod Whiteley is a great speaker and does a lot of rehab with hamstring injuries. And he'll talk about the fact that the best treatment is prevention. And the Nordic or the eccentric hamstring programs are quite effective in terms of prevention, and we'll talk about that at the end as well. The other thing that Rod talks about is the importance of high-speed running as probably the most important component of rehab. So the things that are important for rehab are certainly some exercises that are stretching, that lengthen the hamstring, so stretches that are on the left there, the extender, the diver, the glider. Some of you are familiar with the Askling test, and that's also useful. There's strengthening tests that again include the Nordic hamstring program, but other hamstring strengthening programs as well. There's dynamic walking. And for those of you that might have seen that before, or I might be dating myself with the Monty Python, but it's kind of the silly walk. As it relates to assessments that really are helpful in terms of making the return to sport decision and that are better than MRI, is that length of maximal tenderness, where the athlete is point tender, their ability to have a non-antalgic gait, pain on a bent leg, single leg bridge, and then looking at some certain strength measures. And this shows you sort of the blue is inner strength. This top one is measuring inner strength. And you can see that that normalizes pretty quickly and they're back to normal within a few days. And then this mid-range strength is measured here. It's kind of hard to see, but they're lying prone and you're pulling against their ankle. But the best strength measure is this outer range, which is being measured on this bottom. And that one actually tracks closest to the athlete recovery. And that just shows you two different ways that you can test that, one manually and one with a dynamometer. And lastly, just to end up talking a little bit again about effectiveness, I think most of us are familiar with the FIFA 11 or the PEP program that has been used for ACL prevention. There's been a lot of great work by Holly Silvers and others that have shown that the FIFA 11 is actually also important in terms of preventing hamstring injuries. And you can see that the risk reduction is 63%. If they are in a high compliant group, it actually is as high as 78%. And despite that, they've also shown that the FIFA 11 program also correlates with winning. So not only are you preventing ACL injuries, preventing hamstring injuries, getting stronger, and you're able to win more. Despite all of this, when you look at the literature, there's really not a very good adoption of what we know works, right? So this is a study that looked at UEFA, and they only had an adoption rate of 13% of doing hamstring, Nordic hamstring programs. despite the fact that it was really well shown that when they did them, they actually improved it. It decreased their hamstring injuries and decreased their time loss. So some take-home messages. Soccer is the beautiful game. Hamstring injuries are common and challenging to manage. There are subjective and objective findings that can help us predict return to sport. The rehab should include high-speed running as well as eccentric stretching and strengthening. And prevention is essential, and it also works. Thank you.
Thank you, Dr. Putukian. That was an amazing presentation. Moving right along, I want to remind everyone here, if you have any questions, please hold on to them. We're going to wait for everyone to get through their slides before we start our Q&A. Now it's my pleasure to introduce Dr. Jeffrey Mjaanes. For the last 8 years, Dr. Mjaanes has served as the Director of Sports Medicine and as the head team physician for Northwestern University, where he oversees a multidisciplinary team of sports medicine physicians, athletic trainers, sports dietitians, and strength and conditioning experts. Previously, he was a sports medicine specialist at Rush University Medical Center in Chicago, where he had previously completed his residency in pediatrics. Dr. Mjaanes received his medical degree from the University of Wisconsin-Madison School of Medicine and Public Health and completed a sports medicine fellowship at Advocate Lutheran General Hospital in Illinois. Dr. Mjaanes also has been a team physician for USA Rugby for the last 10 years. He is currently the head team physician for USA Men's 15s national team and is a member of the medical committee for USA Rugby. For the last 9 years, he has also worked for World Rugby and Rugby America North, teaching athletic trainers and physicians standards for pitch-side medical care as a medical trainer, and serving as matchday doctor for numerous international matches. And now it is my pleasure to give you the floor, Dr. Mjaanes. You can go ahead and start.
Thanks. Yes, so I'm going to talk to you about rugby today. How I got involved with rugby was actually I used to primarily work with U.S. soccer. I don't want Margot to take this the wrong way, but I think I came back from one trip, 2-week trip, and said I think all I saw was an ankle sprain. And my athletic trainer at the time, who was my clinician support, told me, you should come watch rugby. I think you'll be a lot busier. So I went and watched a game, fell in love with it, have been working with rugby ever since. You know, it's a fast-paced, exciting sport. I love how there's a lot of challenges with rugby from a sports medicine aspect. Play doesn't actually stop when there's an injury, so you need to ensure your own safety before you kind of run out onto the pitch. As I mentioned, you get to use your full set of sports medicine skills, so there's really no flopping in rugby. Injuries are true injuries. And there's camaraderie. At the end of the match, both teams usually get together and share a beer, and that's what this guy from Wisconsin can actually get into as well. So I thought I'd give a quick overview of rugby for those of you that don't know. I'm going to primarily today talk about rugby union, which is played in over 100 countries across the world. There's 15s and 7s. 15s, that's 15 players on each team, 2 40-minute halves, culminates with the Rugby World Cup. 7 players, 7-minute halves, same size pitch, so much faster pace game, and is now back in the Summer Olympics. I'm really not going to talk today about rugby league, which is slightly less popular than union, except in Australia. You score in rugby by crossing the end zone or the goal line, which is called a try, and you can get 2 points for a conversion. You can also do drop kicks or penalty kicks. You can run or kick the ball to move it forward and pass the ball backwards or sideways. And opponents try to stop the ball carrier by tackling them. And here's a quick video of kind of an older tackle. You can see that they can be quite violent. But nowadays, we try to more teach wrapping your arm around your opponent and kind of bringing them to the ground, as you might be able to see in this video right there. So once or in the picture below, once the ball carrier falls, they have to release the ball. And again, play does not stop. You may have heard about a scrum. This is where you restart after an infringement. You have forwards called a hooker and 2 props, and they kind of bind together with the other team. You can see that in the diagram here. Scrum half throws the ball into the middle. The hookers use their feet to try to hook the ball and kind of push it backwards to where a teammate can grab it and run. A ruck is when the ball is on the ground and you have players kind of close around it and over it, and they try to kind of push their opponents off of the ball. A maul is when one or more opponents kind of grab each other and try to bring the ball carrier down. And then a line out is how you restart play after the ball goes out of the sideline or the touch line in rugby. Forwards assemble in a line, hooker throws in the ball, players are lifted up and try to retrieve the ball and pass it to a teammate. So in just hearing these different plays, you can probably imagine how some of these injuries happen. The most common injuries overall in rugby are very similar to other contact and collision sports. So ankle and knee ligament sprains, hamstring injuries, shoulder dislocations, and then head and neck injuries, concussion, facial injuries, and dental injuries, and spinal injuries. In children and adolescents, so even at younger age groups, we see a similar injury profile. And you can see here in location, head, neck, upper extremity and lower extremity, about a third each in terms of overall injuries. But interestingly enough, in a systematic review of 69 studies in adolescent rugby, head and neck accounted for most injuries in female rugby players. So it's still a significant proportion of injuries here at all levels. And rugby is one of the highest risk sports for C-spine injuries. Fortunately, the numbers of injuries have decreased over the last 30 years or so with some rule changes that have been put in place, primarily starting in the 90s and then in 2014, especially trying to focus on scrum safety. But they still account for a significant proportion of injuries, estimated up to almost 9 or 10% in amateur rugby. And you can see by 4 to 7 out of 1,000 player match hours and how it compares to other locations in the body in community and professional rugby. Fortunately, catastrophic cervical spine injuries are still rare. When they do occur, they do tend to occur more in front row players and then also in the scrum. The types of injuries that we see are strains and sprains and stingers, so mostly mild. You can have disc herniations and ligamentous injuries, but then you can also get serious injuries, fractures, facet dislocations, and fracture dislocations. And some studies showed that the rugby scrum had one of the highest risks for these bilateral facet dislocations, especially at C4-5 and C5-6 of all sports. So the mechanism of injuries we talked about, the highest number of C-spine injuries tend to happen in the tackle, but the greatest severity of injuries still seem to happen more in the scrum. And our highest risk positions, again, then hookers and props from the scrum, and then backs from tackles. The mechanisms of injury here, the biomechanics, hyperflexion was thought to be one of the main causes of these injuries, primarily due to the scrum. Either direct impact against their opponent or collapse down, which I will show you in a second a video of. Axial loading, though, is actually thought based on cadaveric studies to be probably one of the more common causes more than hyperflexion, as this axial loading, which can also happen with these same mechanisms, can lead to buckling of the spine and then facet dislocation. Hyperextension injuries were thought to be fairly rare, but actually now in the last 20 years, since we've been teaching players to keep their head up and out of the tackle, there's actually a higher rate possibly now of hyperextension injuries to the C-spine. So in World Rugby, they teach us to have a high index of suspicion for the following circumstances. In the scrum, head impact at the front row on engagement, and you can see in the picture here what that kind of looks like from a side view. Now imagine all that force behind it, and you can definitely have a C-spine injury. A collapsed scrum, and here's a quick video to kind of show you what a collapsed scrum can look like. You can see right here how the neck could easily get injured. Front row popping is where a front row player, prop or hooker can pop up in the scrum, so that can be a type of hyperextension. Obviously, in a tackle, you can have a direct head impact or a spear tackle, which is different in rugby than in football. And spear tackle in rugby is where the player is actually lifted up and then dumped onto their head onto the ground. It's an illegal move, but it can still happen. You can also get neck injuries from a squeeze ball, which is a player holding the ball on the ground, tries to squeeze it out through their legs. They can get stepped on, and then a fall from a height, such as in the line out, which I showed you before. So diagnosis on the pitch, we have to have that high index of suspicion whenever we see one of those high risk mechanisms. We would address any catastrophic bleeding, go out and maintain C-spine stabilization until we can kind of prove that it's not the C-spine, maintain a patent airway, breathing and circulation with special focus on signs of neurogenic shock. Do a brief neurologic assessment, which is going to look at level of consciousness, any tenderness or pain from the spine, a brief sensory and a brief motor exam. and then determine our disposition here. Are we spine boarding and transporting, or can we clear the C-spine on site? Who we might stabilize the C-spine in would be anyone with an altered level of consciousness, spinal pain, tenderness, or deformity, any loss of normal cervical motion, any neurological deficit, or any distracting injury. And this is actually quite important in rugby because you can have multiple injuries at the same time. Think a tibial fracture, femur fracture at the same time as a neck fracture. That tibial fracture may distract the patient and they may not be able to tell you about their neck pain. Management and recovery, then we place them usually still in a cervical collar and a board. We still have a long spinal board as the primary means, but it really depends on what you have in your disposal. Scoop stretchers don't tend to work well for rugby players. They tend to be pretty large humans, and so they may not fit well on a scoop stretcher. Vacuum splints or vacuum mattresses, should be used for longer transport. And then obviously transport to a major trauma center if indicated for further management. But as we know in this country and some newer papers that have been released, that for most of us, we're gonna now call this more spinal motion restriction because we know we truly can't immobilize the cervical spine. Want to maintain that circulation and then airway and breathing as well. And then still consider cervical collar, consider boarding, but really I would encourage all providers to talk with their local EMS. In the last several years, we've seen some changes, not only in some studies showing some weak evidence for things like cervical collars, but also in the need for local and state EMS kind of rules, which predominate as to whether they might put them in a collar, whether they will board or not, the type of device that they use. And then if you're covering a sport like football or hockey or BMX, whether equipment should be removed prior to boarding or not. And again, like Margot, I'd like to kind of focus a little bit on prevention. In rugby, for prevention of cervical spine injuries, we're going to talk mostly about rule changes and education. For example, the tackle, we want to make sure that we are wrapping around and pulling the ball carrier to the ground. No tackles above the shoulder are legal. And actually now World Rugby is implementing a lower tackle height, which is below the sternum, to try to prevent those head and neck injuries. In the scrum, making sure that players are ready to engage in the scrum and that they're not engaging when there's a large mismatch of skills, strength, or size. And officials have the right, and often do now, reset scrums if they look like they're going to be unstable. But again, then that secondary prevention and preventing further injury by that proper pre-hospital care that we talked about, and rehearsing as a team, practice with your primary healthcare professionals. Thanks.
Thank you, Dr. Mjaanes, for your presentation. Moving right along, I'd like to introduce our next speaker, Dr. Alison Brooks. Dr. Alison Brooks is a tenured professor in the Department of Orthopedics, Division of Sports Medicine at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. She serves as the primary team physician for Badger women's ice hockey, the Forward Madison Football Club, and the Madison Radicals Ultimate Team. Dr. Brooks' interests in pediatric sports medicine include healthy youth athlete development, injury prevention, and the benefits of time outdoors in nature. Dr. Brooks was a Tar Heel before she became a Badger and played college soccer at UNC. Now she's an avid mountain biker and recently did a 2-week bikepacking trip in Montana. Please, Dr. Brooks, the floor is yours.
Thanks for the opportunity to talk to you. I don't have any financial disclosures related to this presentation, and I am the team physician for the Madison Radicals Ultimate Team, which is a professional ultimate disc team here where I live. Quick overview, we'll talk about the history of ultimate, how I got involved, some unique biomechanics of the sport, briefly touch on sort of, some overuse and acute injuries, but then our textbook injury will be AC joint injuries, and talk about evaluation, treatment, and return to play. The history of ultimate actually started in the 1920s. The original Frisbee was actually a tin pie plate from the Frisbee Pie Company in New Haven, Connecticut. And people figured out you could throw that back and forth and kind of made a game out of it. Then in 1948, this gentleman named Fred Morrison actually made a plastic version called the Flying Saucer. It's the blue one on the left. And then a couple years later, he made the yellow one called the Pluto Platter. And then in 1955, the Wham-O Manufacturing Company bought his patent and renamed it Frisbee. In the late 1960s was the start of Ultimate, the sport or the game was credited to some high school students in New Jersey who like invented it. They created it as a game, as sort of a form of Frisbee football. And then they jokingly sort of dubbed it the ultimate sports experience. And so the term ultimate stuck. And the first sort of recorded collegiate game occurred in 1972. And sorry, Dr. Putukian, but Rutgers beat Princeton. And you can see down here, you know, that the far right, the bottom right is sort of one of the original versions of the Frisbee. And it's evolved some from there. But now we have professional Frisbee. It used to be called the American Ultimate Disc League, or AUDL, and it was founded in 2012. It was just last year renamed to the Ultimate Frisbee Association, and you can see all the teams there. And we're lucky here in Madison to have a professional ultimate team. We also have an NGO, a national governing body. It was recognized by the USOC in 2014 and the IOC in 2015. Despite their sort of petition for inclusion, they were not included in the upcoming 2028 Olympics in LA. There are international competitions in the World Games and World Championships. There's a male, a female, and actually a mixed division. In the last World Ultimate Championships, the US won gold medals in all three, which is maybe why they didn't let us have it as an Olympic sport. we are quite dominant in terms of winning this sport every year thus far. But there's collegiate teams. I'm also fortunate here in Madison, our University of Wisconsin, our club team are the Wisconsin Hodags. The high school that my son will go to, Madison Memorial, has a high school ultimate Frisbee team. And then there's a great recreational league here in Madison. So it's a very popular sport where I live. And lots of opportunities to play either at the recreational or competitive level. How I got involved, like Margot, I was an old soccer player. Played in college, you know, played afterwards. And then I kind of got to a point where after 30 years of competitive soccer, I was kind of ready for a change. And so one of the PTs that I work with here at UW Health said, hey, you know, I play Ultimate Frisbee. You know, there's a really fun summer league. We're always looking for, you know, women, you know, who played similar, you know, a sport like, you know, soccer. That's an easy transition to ultimate. And hey, come join us. And this was a bunch of other working professionals with young kids, and my son was young at the time. And the name of our team was Sideline Daycare, because the expectation was when you weren't in the game, you were daycare. You were taking care of everyone's kids on the sideline until it was your turn to go in the game. So here was my son with me at one of the games when he was about 4, having fun throwing the Frisbee. And then, of course, after a little while, the duck feather he found was more interesting. But the other fun thing about our Ultimate League, Jeff, a shout out to Wisconsin. It was sponsored by Great Dane Brewing. So every team got a beer card. And so after your game, you would go to the Great Dane and you would get 2 free pitchers of beer. So who doesn't love that? So I played competitive Frisbee here in that fun league for over 10 years. And then another physical therapist that I work with approached me about would I be willing to be the team physician for the Madison Radicals, because prior to that, they really didn't have much medical coverage. You know, they were sort of on their own, and they really wanted to sort of increase physician coverage and access to timely medical care when they needed it. So I've been serving as their team physician for about 5 years now. How to play Ultimate, and I put Frisbee up there because Frisbee is a trademarked term, right? It's a trademarked product, so thus sort of referring to it as just Ultimate or Ultimate Disc. It's 7v7. You advance the disc by throwing it. You can throw the disc forwards or backwards. So unlike other sports, right, you can You can advance it in any direction that you want, kind of like soccer. But you can't run with the disc. So once you catch it, you have to stop and then establish a pivot foot, maybe sort of similar to basketball. And then you score points by catching it in the end zone. The size of the field is similar to an American football field, not exactly the same dimensions, but pretty close. So, and it's non-contact in theory. But obviously when two people are going for the disc in the air, there are collisions, there is contact, and then it's sort of a, subjective, whether or not that, was enough contact to call a foul. But I really think of Ultimate as sort of a beautiful blend of soccer, rugby, and American football in many ways. There are sort of two main positions, although really players flex in between all these positions, but you have some players who really are good at throwing, so then they're called handlers, and they may do most of the throwing of the disc. And then you have cutters, which are essentially like receivers. And just like in football, there are different schemes, offensive schemes, or different plays that you run, right, to try and get your receiver open to catch the disc. Biomechanics, it's really very different than a sport like baseball, where you're sort of doing the same repetitive overhead motion. In Frisbee, there's lots of different release points, anywhere from all the way down at your ankle to above shoulder height. You might be throwing it sidearm or overhead. You might be trying to have the disc fly flat or be arced. You have to quickly switch between all these different positions. You're lunging with your non-pivot foot to try and get around the defender who's sort of guarding you like someone would guard you in basketball, right? If you've stopped dribbling and you're trying to, move around your pivot foot. You might be squatting really low to the ground to try and get underneath their arm to throw it without them blocking the disc. And then you start to generate power to throw with trunk and pelvis rotation. The wrist is cocked, and then you sort of flick the wrist to generate the spin. The two kind of most common or well-known types of throws in Frisbee are this top one on the left is called the forehand, or sometimes referred to as the flick. This one on the right is probably how most people think of like how you throw the Frisbee, but that's actually called the backhand. This throw down on the bottom left is called the hammer, and overhead. And then this one here with the disc actually sort of flipped upside down is called the scoober, and if you throw it the length of the field, you call that hucking. And how can you not like a sport that has words like huck and scoober? Different ways to catch the disc. There's what's called on the top here a pancake catch, so catching it with both hands together, which right is the safest way to try and catch it and not drop it. Or what's called a crab catch, right, where you're using your hands like a crab claw and trying to, pinch it between your fingers on top and your thumb below. And then in terms of the kind of textbook injury, we're going to talk about laying out is a really important skill in how you try and catch the Frisbee. I don't know if this video will work. We'll try it. Let's see. All right, so that gives you an idea of what a proper layout, we sort of call it a Superman And the pictures down here sort of demonstrate the position that you should be landing in. And obviously, Frisbee is like soccer and other sports where there's a lot of cutting, pivoting, jumping, landing, but we're going to focus more on the layout as our injury mechanism for our textbook injury. Overuse injuries, obviously lots of running and jumping. So patellar tendonitis, Achilles tendonitis are common things that I see. But because of all of the varied releases and all the different types of throws in Frisbee, it might be sort of counterintuitive, but wrist overuse injuries are actually not common because there's so many different positions that are putting their arm and their wrist in. So that seems to be protective. Acute injuries, obviously with other cutting, pivoting, jumping, landing, ACL tears, ankle sprains. PCL injuries can also be a problem with not laying out correctly. So if they land more on a bent or a flex knee, they can sustain a PCL injury. Certainly a shoulder dislocation if they land awkwardly with their outstretched arm or reaching out and their arm is struck by another defensive player. But the one that we're going to focus on is AC joint injuries, or AKA shoulder separation. The mechanism really most often is a bad layout, definitely not super. So falling onto their lateral shoulder like this with their arm adducted, the top picture, or falling like this onto an outstretched bent elbow that then drives all that force up to the AC joint, rather than this picture down here on the bottom, staying parallel to the ground and sort of sliding forward with both hands and arms to the chest. The Rockwood classification is, the most commonly used to sort of type or grade these injuries. A type 1 is where you stretch the AC ligament, but it's not ruptured. A type 2 is where there's partial rupture of the AC ligament and capsule, but the coracoid ligament or the CC ligament is still intact. The type 3 is where there's complete rupture of the AC and the CC ligaments. A type 4 is where there is posterior displacement of the clavicle. The type 5 is like a type 3, but there's even more superior displacement of the clavicle, potentially even tenting the skin or resulting in an open injury. And then a type 6, which is extremely rare, but where there's an inferior displacement that could actually compromise vascular structures below. By far the most common ones that we see in Ultimate would be a type 1, 2, or 3. Again, a type 1 is where you've stretched or sprained the AC ligaments, but the CC ligaments are intact, and those will often look normal on plain radiographs. A type 2 is where you've disrupted the AC ligaments, you've sprained the CC ligaments, and there may be some elevation of the distal clavicle, and you may see some widening and slight elevation of the clavicle on plain radiographs. And then a type 3, where there is disruption of both the AC and the CC ligaments. The distal clavicle is essentially unstable, and on plain radiographs, you may see much more significant elevation of the clavicle, 25, to 100%. When evaluating these athletes, they're going to usually have some swelling over the AC joint, some deformity at the AC joint if it's a type 2 or 3, depending on when you see them related to the injury. They may have some ecchymosis that's developed. They're going to be painful when you palpate their AC joint. If you do this crossover test, which is the top picture on the right, which is essentially compressing that injured AC joint, that is painful. They can have pain and even some laxity with this sort of bottom picture where you distract the AC joint caudally or axially, however you want to describe it. If they have a type 3 injury, they may have what's called a piano key sign, where if you push on the distal clavicle, because it is really not attached ligamentously anymore, it will move. You can compress it or depress it down, and then when you release, it comes back up, kind of like when you're pushing on a piano key. Athlete Athletes really should have full passive range of motion, but their active range of motion definitely can be limited due to pain. And they should have normal rotator cuff strength. Generally we wouldn't see, a significant rotator cuff tear in a young athlete, but it's not impossible. On plane radiographs, we want to do them partly to rule out a distal clavicle fracture, which you can sometimes see associated with these injuries. And then it can help us assess the type of AC injury and pair that with what we already suspect on our clinical exam. This would be an example of a type 3 on the right shoulder here, where there's clear deformity at that AC joint. And then on the right here is what it might look like on plane radiographs with, near 100% displacement of the distal clavicle. Treatment, sometimes a sling for comfort, very short term, but I really caution athletes about using it for very long in terms of being worried about shoulder or elbow stiffness. Sometimes I have high school athletes use it just to walk in the hallways at school, just so kids remember to, keep their distance and not bump into them if they're pretty sore. NSAIDs and ice. Rehab definitely for higher grade injuries. I think some really minor type 1s, they might be able to sort of rehab themselves and not need to see a physical therapist. I found that taping the AC joint like this picture on the right can be helpful, especially if it's a more severe injury. There's instability of that. Taping the end of the clavicle down could give the athlete comfort and also sometimes allow them to return to play a little quicker with the tape there. In terms of injecting the AC joint to allow them to play, I would say that's not standard of care for the vast majority of athletes I take care of. If an athlete was going to play in the national championship in a couple weeks and they were still a little sore, would I be willing to inject it? Maybe. But I would say injecting the joint just to make the pain go away is not something I would do for every athlete that I see. Surgery, almost never for types 1, 2, and 3 for the surgeons that I work with. They will pretty much never do it for cosmetic reasons. And they will really only consider a surgical reconstruction of the AC and CC ligaments if, despite conservative treatment, the athlete still has persistent pain from instability or crepitus at the AC joint and is just unable to regain functional motion and strength despite being compliant with an appropriate rehab program. But the recovery from surgery is long, so it doesn't get an athlete back to play sooner in most cases. Most athletes do well and can return to play the same season, obviously depending on when in the season the injury might have occurred. They can return when pain is controlled. They've got full functional range of motion and strength. On average, of course, a type 1 is going to return faster than a type 3. These are just sort of guidelines. Every athlete rate can go faster or slower. But a type 1, realistic maybe in 2 to 3 weeks, a type 2, 4 to 6 weeks, and a type 3 in 8 to 12 weeks. Although I'll tell you, I take care of hockey players. I've seen hockey players with type 3s be back playing in 3 to 4 weeks. And I think it's always important to just talk with the athletes about the potential for post-traumatic AC joint arthritis, right? Anytime you injure a joint, like we know with the ACL and the knee, right? An injury to the joint increases the risk of post-traumatic arthritis. And so just, counseling them about that. I would say most of the time that doesn't necessarily require treatment in the future, but every now and then I will see someone who had a bad AC injury when they were younger and they're in their, 50s and have really severe AC joint arthritis and actually may see one of my surgical colleagues, for a procedure to sort of clean out that arthritic joint if it's really causing them lots of pain. This is Bree Stevens. It's actually his historic stadium dates back to sort of Civil War era, but this is where our Ultimate team plays. It's a great venue and you can see there's lots of people there to watch Ultimate. It's a very popular sport here. So thanks.